This is my disclosure. And the present study is a continuation of our previous published article, where we showed that full endoscopic surgery can raise intracranial pressure to critical levels due to continuous saline infusion, and mainly when the drainage channels are occluded. We did that in the lumbar spine of the pig, as you can see here in this video. When we occlude the drainage channel, sorry about the sound, when you occlude the drainage channels, the intracranial pressure raises to almost 40 millimeters of mercury. And this effect worsens with higher irrigation pump settings and causing, in a real life surgery situation, headaches, neck pain, and there are several reports of visual loss and seizures. So in the present study, we aim to evaluate invasive ICP profile during cervical FAS, this time in swine, using different settings of pump parameters and also different occlusion tests and different anesthesia depths. So that's how we did it. We got 4 pigs. They were performed intravenous anesthesia. Then we performed a burr hole in the frontal part of the skull to insert a ICP parenchymal catheter. And then with the fluoroscopy, we inserted the dilator and the cervical interlaminar cervical spine, in the interlaminar window of the cervical spine. And then with a 4.3 working channel endoscope, we did the exposure of the cervical spinal cord. We use continuous saline irrigation in progressively higher parameters. So we started with configuration A when we had 60 millimeters of mercury, then 90, 120, and 150. We attempted mild sedation with low doses of propofol and fentanyl, and then we tried to deepen the sedation, increasing the anesthetic drugs and checking for apnea and reduction of blood pressure. And each pump setting was tested under open drainage channel, partial or total occlusion of the outflow. Safety was established as ICP below 20 millimeters of mercury, and that's what we got. In the first pig, as soon as we opened the ligamentum flavum, the ICP increased for over 20 millimeters of mercury, and it stayed like that throughout the surgery. You can see when we did the occlusions, we had ICP as high as 80 millimeters or almost 100 millimeters of mercury in configuration D, but also in configuration A, when we had 60 millimeters of mercury in the pump, we also had ICP as high as 40 millimeters of mercury. The first pig was very strong. It was very difficult to deepen the sedation. With high doses of propofol and fentanyl, we couldn't reduce the blood pressure or induce apnea, so we considered this one a mild sedation. On pig 2, it was the opposite. It was very easy to make the anesthesia, and look how the ICP stayed under control throughout the whole procedure. Even when it did occlusions, you can see in configuration A we had above 20 millimeters of mercury, but below 27. So it was very safe to operate this pig. And we consider this one a deep anesthesia. In pig 3 and 4, we were able to test 2 types of anesthesia. So with low doses of propofol and fentanyl, look how mild sedation permitted high increases of the ICP as high as 60 millimeters of mercury in configuration B. And when we increased the doses of the anesthetic drugs, we could control the ICP throughout the whole procedure, including with the occlusion tests. The same happened in pig 4. So as a conclusion, cervical FAS causes more frequent and severe ICP elevations than lumbar FAS. ICP may exceed 20 millimeters of mercury immediately after flavectomy because it's very close to the brain compartment, and can reach critical levels with partial or total drainage occlusion. And deeper anesthesia and mainly keeping the outflow going, you can help prevent ICP rises and improve safety in this kind of procedure. Thank you for your attention.
Thank you. to ask you, well, I was quite surprised with having like the big who have different levels of anesthesia that you could not. I hope our anesthesiologists don't do the same for humans, but as far as I understood, you wouldn't recommend like endoscopic surgery and local anesthesia, or do you have any clue about that?
Yeah, I think in the beginning I used to do a lot of surgery with local anesthesia and anesthetic drugs, and I used to have patients complaining from headaches and neck pain, and about 8 years ago I switched to general anesthesia, and I never had this problem anymore. So, and I wanted to show that there's some sense in doing general anesthesia, especially the cervical spine, where the brain compartment is very close, so to protect from ICP rises, for sure general anesthesia is better. And we use neuroprotective drugs in higher doses.
So the conclusion of your study is just the same recommendation from the study from the Zurich group from Farshad. They suggested not raising the pump pressure over 20 millimeters HG in cervical spine procedures. So we really have to focus on that, not to close the water flow exits.
Yeah.
Because that really rises, and you showed it really nicely up to 80 millimeters, and that gives them some problems. I think this usually happens when it starts to bleed, so we have to make sure not to use any higher pump pressures there. Right?
Yes, good.
Yeah.
This presentation is my question. My name is Walid Jaffi, UEA. My question on Dr. Amato. Does the shape of endoscope and working sleeve considered in your study? As we know, there's different shapes. There's working sleeve oval or endoscope oval as a safety for the increasing of intracranial pressure during the endoscopic surgery.
Yeah, no, I just used one type of endoscope and working channel, and there is different types of safety devices in the different brands of endoscopes. And this kind that I use is a dual-port irrigation. So you have one irrigation channel that works for the outflow, and also the working channel works for the outflow. So that's why I have to close both channels. And yes, there is an endoscope. There is oval, and you have a round cannula, and you have outflow going through this channel. And so there are different types, and the surgeon must be aware of what device he's using. Otherwise, he can, for example, in this kind, he puts a rubber cap in the working cannula and uses high pressure, he will have a problem. So, and in this device that I use, what I recommend always is to check if the outflow port is not obstructed. I usually use a syringe to flush some water, because it's very common for pieces of bone or ligaments to enter this drainage channel, and then it is obstructed. And then you use like a Carison arrangeur, and it completely obstructs the channel. So you think you are not making an obstruction, but you are, and you don't, it's feeding during the surgery, you know? So I recommend to check that.
Okay, thank you very much for your presentations and for the discussion.